So you've spoken about these three classes of medications. There's lithium, and then there's what medicines that were once used for seizures but are used for bipolar, and then a different class of medications that are also used. Can you talk about is there an order in which those should be used, or does it depend on the clinician? You mentioned one factor, which is the availability of testing, and someone in a rural area might be better off with quetiapine or these other agents.
I am asked that question every day. Which is the best? And they are all about the same if looked at on the average in a group of patients. But we try to fit the right medicine to the right patient. And if there is a family history of response to lithium, lithium is first. If there is unavailability or lack of desire for the patient to have blood tests, then lithium and valproate and carbamazepine would be second, and we would. If there is a high risk of weight gain or a great aversion to weight gain, especially in a young woman patient where weight gain might be a real risk, we would then put lithium or carbamazepine, or of that last group, aripiprazole also is weight neutral, doesn't increase weight gain. And so if a patient has a history of kidney problems, we would stay away from lithium. So we try to fit the right medicine to the right patient. There isn't any one of them that's overall better. Sometimes one doesn't work. Very good research evidence proves that if one doesn't work, don't give up. The others may well work. There is no such thing in my 40 plus years of experience as a patient who responds to nothing.
That's very
encouraging. The
encouraging.
patients who stay with me get stable. And I've had so much satisfaction over the years of helping people with such severe, clinically difficult mood swings, who I will help to achieve stability through the right medications and some other advice which I can tell you about. But the key thing is if they keep coming back to me. I don't have a one-time answer for anybody.
So it's a theme. You've said it so many times, it's probably worth emphasizing this notion that really the goal of treatment in bipolar is maintaining stability over time. And it requires ongoing treatment and an ongoing relationship with a psychiatrist who can actually, and you're saying that based on 45 years of experience treating patients, it sounds like.
And the other thing I would add is a relationship with the family who can call and warn the doctor if there's a change or the patient has stopped taking his medicine. And these lifestyle factors are so important as well. Once the acute illness has been stabilized, one can begin discussing with the patient and the family that the patient with bipolar disorder should not stay out until 3 a.m. at parties. That an important thing is a regular sleep time, regular meals, regular exercise, keep the weight under control. Good present for every bipolar patient is a scale. It's amazing. Many people don't have weight scales in their home, and everyone needs to have a scale.
No, so why do they need a scale? Is it because they tend to eat more from mania, or because of the medications, or what?
Several of the medications increase weight, but also obesity increases the severity of the illness. A person needs to feel light, needs to have exercise, needs to want to be active. And of course, in depression, it's hard to get people moving, and if they're not obese, it's easier. So emphasis on the lifestyle is a good way also to get people talking with this illness and to get a doctor-patient relationship with them, and also for the families to relate to them with something that's concrete but does help them keep stability and keep rhythm and keep order in their lives.